Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what's happening in this image right here? What organ is this even? Oh, okay, it's starting to make sense. Okay, uterus, okay, ligaments. What are those red arrows pointing to? Is that an ectopic pregnancy medical emergency? We're going to be discussing this and much more in this presentation on gestational pathology. This is covered in your book along with many other topics that you must know. Medical school pathology and step 1 review. You can scan the QR code to get to the updated material. Gestational pathology. What is that? Well, gestational pathology is pathology of the placenta or the embryo. Now let's take a pause here for a moment because this is very important. If you rotate through OB-GYN, you're going to see this, and future OB-GYNs be on the aware for this. Ectopic pregnancy. This is what it looks like from the laparoscopic view. Pathology that we're going to talk about is going to include ectopic pregnancy, which is a medical emergency, spontaneous abortion, placenta previa, placental abruption, placenta accreta, preeclampsia and eclampsia, HELP syndrome, SIDS, a hydatiform mole, and choriocarcinoma. An ectopic pregnancy is what happens when the fertilized ovaries are being implanted anywhere other than within the uterine wall. Ectopic pregnancy most frequently occurs in the fallopian tube, which transmits the eggs from the ovaries to the uterus. That's the site where the ectopic pregnancies most frequently occur. Key risk factors for ectopic pregnancy include scarring, such as that secondary to pelvic inflammatory disease, and endometriosis. A few weeks after a missed period, women who have an ectopic pregnancy may experience irregular bleeding and lower abdominal pain or pelvic pain. Ectopic pregnancy, as you know, is considered a surgical emergency. To the right here, we could see the surgery occurring on an ectopic pregnancy, right? You can visualize that in A and B. And then in C, we have the histologic representations of the tissue that was removed and stained with H&E. And what you're seeing is embryonic tissue within a fallopian tube. Major complications of an ectopic pregnancy include bleeding or bleeding into the fallopian tube, which is a hematosalpinx, or it could even rupture. Now, what's a spontaneous abortion? Well, a spontaneous abortion is fetal miscarriage that occurs before 20 weeks of the pregnancy. To the right here, we have a transvaginal ultrasound after an episode of heavy bleeding in an intrauterine pregnancy that had been confirmed by a prior ultrasound. So, unfortunately, there is some widening between the uterine walls, but no sign of any gestational sac. Thus, this is diagnostic of a complete miscarriage. Spontaneous abortion typically occurs in the first trimester. You might be asked that. Spontaneous abortion is common and actually happens up to 1/4 of recognizable pregnancies, so it's pretty common. Symptoms of spontaneous abortion include vaginal bleeding, cramp-like pain, passage of fetal tissues, and causes of spontaneous abortion include chromosomal anomalies. Can you think of any? Maybe what's the thing that causes hydrops fetalis with the malfunctioning hemoglobin? 4 alpha chains, right? You know that. Or 4 defective alpha chains that are inherited. Hydrops fetalis. You can have chromosomal anomalies. Hypercoagulable states can do it. Antiphospholipid syndrome and teratogens, right? Effects of teratogens typically occur within the very first time frame of... I'm distracted by this image here. Sorry, I should have given you a trigger warning or some sort of graphic notice. You can read this slide if you want. We're going to move on. Okay. Placenta previa is a pregnancy problem that occurs when the placenta totally or partially blocks the uterine entrance, i.e. the cervix. Placenta previa usually presents as third trimester bleeding. Placenta previa often requires a C-section, which is a procedure delivering a baby through a surgical incision made in the abdomen and uterus, right? And here we can see that placental abruption is when the placenta is separated from the decidua before the fetus is delivered. Placental abruption is a common cause of stillbirth. The latter trimester of pregnancy, particularly the final few weeks before delivery, is when placental abruption is most prone to happen. Symptoms of placenta abruption include uterine soreness, abdominal pain, and vaginal bleeding. Placental or placenta accreta is a serious pregnancy condition wherein there is an improper placenta myometrium implantation with minimal to no intervening decidua. Placenta accreta is often recognized during labor with difficult delivery of the placenta and postpartum bleeding. C-section and or hysterectomy may be needed to treat placenta accreta. And here we have a cartoon showcasing various forms of pathology such as accreta, increta, and percreta. In regards to preeclampsia now. Preeclampsia is edema, proteinuria, and hypertension, importantly, that are conditions brought on by pregnancy that often appear in the third trimester and affect about 5% of pregnancies. To the right here, we have a high magnification micrograph of hypertrophic decidual vasculopathy as seen in a pregnancy-induced hypertension, such as preeclampsia. In preeclampsia, the hypertension may be severe, leading to headaches and even visual abnormalities. Preeclampsia is due to an abnormality of the maternal-fetal vascular interface in the placenta. Preeclampsia resolves with delivery, and that's important to remember. And here we have a cartoon showcasing what normally occurs, right? We have normal blood flow from the spiral artery to the maternal blood flow. And compared against preeclampsia, notice the vessel diameter is decreased significantly of that spinal artery there. And then we have some histologic sections from a tissue that was obtained from a patient that was experiencing preeclampsia. Notice the changes to the decidual tissue and specifically the trophoblast cells. Now, eclampsia. Eclampsia is preeclampsia with seizures. Eclampsia has seizures. And we can see that this eclampsia is actually a part of another condition that we're going to touch upon early, but I'd like to guide you to this image that's showing a CT scan of the onset of eclampsia, showing multiple low signal density areas in A, and then fluid attenuation in B. Now, HELP syndrome, hemolysis, or hemolysis, depending on how you pronounce it, elevated liver enzymes, and low platelet syndrome is preeclampsia in combination with liver-related thrombotic microangiopathy. Both eclampsia and HELP syndrome usually warrant immediate delivery. Now, something that can happen after delivery to a young patient, a baby, is sudden infant death syndrome. Sudden infant death syndrome occurs when infants ages 1 month to 1 year old who suddenly died without an apparent cause. Sudden infant death syndrome is usually associated with issues with the baby's inability to wake up and expire during sleep. Risk factors for sudden infant death syndrome include exposure to cigarette smoke, another reason to not smoke tobacco, prematurity, and sleeping on your stomach, or the baby sleeping on their stomach, I should say. It is believed that this ties into neurological issues related to seizing or parts of the brain not properly regulating cardiac input or respiration. That's all theoretical. Here we have a gross heart that's been splayed open, showcasing left ventricular hypertrabeculation in a 3-month-old infant that suddenly passed away to sudden infant death syndrome. It's postulated that the apical area was involved with an arrhythmia that led to the fatal demise of the baby. Now, let's talk about hydatiform moles, because this is very important and easy to get tricked up on. A hydatiform mole is a condition that is marked by enlarged, swollen, and edematous villi and trophoblast growth. To the right here, we can actually see the histopathology associated with an hydatiform mole. This is the complete type. A hydatiform mole is known as a molar pregnancy. A hydatiform mole causes the uterus to expand as though a normal pregnancy is present, but it is significantly larger and higher than predicted for the gestational age. Hydatiform moles are detected during pregnancy or prenatal care with a routine ultrasound in the early first trimester, which will classically show an absence of fetal heart sounds, and an ultrasound with a snowstorm, buzzword, snowstorm appearance. A hydatiform mole may be recognized on physical exam as a buzzword, grape-like lump passing through the vaginal canal. Hydatiform moles are classified as complete or partial. You can have the complete hydatiform mole, which is diploid, 45XX, or the partial hydatiform mole, which is triploid, 69XXY. Treatment of hydatiform moles includes dilation and curettage, right? A D&C, get it out. To guarantee adequate mole removal and to check for the emergence of choriocarcinoma, follow-up monitoring is crucial. A hydatiform mole, a normal pregnancy, or a spontaneous germ cell tumor can all result in choriocarcinoma as a gestational complication. And you remember this histology, right? See the hemorrhage, the nuclear pleomorphism. This is a choriocarcinoma. Choriocarcinoma may also arise as a spontaneous germ cell tumor. Choriocarcinoma is treated with chemotherapy for you future oncologists out there. Chemotherapy is more effective in treating choriocarcinomas that develop along the gestational pathway, opposed to choriocarcinomas that develop via the germ cell pathway. And you have completed another very important presentation. There's a lot of nuggets in here that you must know. Great job. As usual, you're killing it. You're doing a great job. Keep up the good work. You're making me so proud. Keep making your family proud. You're holding the torch. I'll see you next time. Till then, take care.